Okay, so the next thing we're going to talk about are powers, and powers refer to the contractions. Involuntary contractions actually happen throughout pregnancy, but they tend to be milder and much more irregular. They become stronger, more noticeable, more regular, shouldn't still be painful until near time for actual labor to begin. Okay, so those contractions start in the thickened upper segment and they move in waves through the uterine muscle. So this contraction, we pull, this muscle contracts, pulls more of the uterus up behind the fetus. At the same time, that contraction is pushing down. So we're contracting, pushing down, fetus is being pushed forward, uterus is being gathered up behind the fetus. Okay. Now, the bag of waters is normally intact until near the end of labor if it's not ruptured artificially. Sometimes it ruptured spontaneously earlier in labor or even before labor begins. Typically, on average, though, it's going to be later in labor. So that bag of waters kind of evens the pressure. So there's this even hydrostatic pressure as the baby's being pushed down and the uterus is being gathered up behind the baby. Okay. The contractions are intermittent with rest periods in between. As labor progresses, they get stronger, longer, closer together with shorter rest periods. But they may start out 10 or 15 minutes apart, really gradual change. We describe contractions three ways. We describe the frequency, and when we're counting frequency of a contraction, we count from the beginning of one to the beginning of the next. Sometimes patients will come in with my contractions are 3 minutes apart, but they're timing from the end of a contraction to the beginning of a contraction. We want to time from beginning to beginning, okay? Beginning of one to the beginning of the next. That's not usually a fixed interval. It's usually more of a range. Tends to get more regular as it goes along, but it's more of a range. It'll be every 10 to 15 minutes, then every 8 to 10 minutes, then every 5 to 7 minutes, then every 3 to 5 minutes. So it kind of gradually changes. Duration is how long those contractions last. And this is looking from beginning of a contraction to the end of the same contraction. And again, it tends to be a range. You might have a contraction that lasts 40 seconds. You might have a contraction that lasts a minute. The next contraction might last 50 seconds. So we're looking at what is the range, okay? Intensity is how strong are those contractions. We can palpate those contractions, and we would describe as mild, moderate, or firm. Mild means we can feel contraction. It's still easily indentable. Moderate, we can feel that contraction. It's firmer, but we can still push in. We can still push the uterus in. A firm contraction, when you try to push, that muscle is so tightly contracted, it's not going anywhere, okay? So we call them mild, moderate, or firm. And we all three of those increase as labor progresses. The contractions get longer, stronger, closer together. Okay. Sometimes after full dilation, there's a rest period and the patient may not perceive any contractions. They felt that last couple of centimeters of dilation can be brutal. The contractions can be one on top of the other with very little rest. A lot of times the last couple of dilations of the cervix trigger some vagal type responses. They may have nausea, vomiting, shaking, sweating. They may have some systemic things go on. And then once the cervix is gone, completely dilated, a lot of those symptoms go away. They may not feel contractions for a little bit. Okay, so we're fully dilated. Those contractions are continuing. What they're doing is gathering the uterus up behind the fetus. They may or may not feel them. Now, at some point, they continue to push the fetus down further. At some point, the presenting part gets to the pelvic floor and begins to stretch it. And there are stretch receptors that activate a bearing down reflex. And then we have involuntary pushing. So the urge to push is involuntary. Someone who is completely paralyzed will still have involuntary pushing. Someone with an epidural will have involuntary pushing. It can be blunted a little bit by nerve damage or by anesthesia, but it is still there. We also can use voluntary muscle to help that push. And so this is when people may be actively pushing. Okay. The next section we're going to talk about is position. And this is more in relation to the position of the mother, because we talked about presentation and position of the fetus.